elimination, pattern recognition, and things like that. And you know where your knowledge needs to be expanded as well. So the single-handedly the most important thing for MBBS preparation, MCQ prep, is doing MCQs, right? It is way more efficient and way more effective than just studying. Um, if I had to choose one, if I just had to choose reading the entire book of Oxford or just doing 500 questions on the different topics, I would every day do just 500 questions, right? Obviously, you want to combine the both and expand your knowledge as much, but the point is make sure you're doing as many questions as possible on a daily basis, right? MBBS is now, I think, exactly 2 months away because May the 19th is about 2 months away, right? Yesterday would have been the 19th. So now it's crunch time, right? Good. Anything else I want to address? Um, so for my St. Augustine students, you will be very, very happy, extremely elated if you do my OSCE course. Um, that's what I'll say about that for my St. Augustine students, right? Um, yeah, I'll keep that as that. So I will start advertising probably in April. I'm not sure when I'm having it. I still have to decide the days. Ayana would have told me that you all finish April the 11th, which gives us some time to kind of play with and gives you some free time. So I'll decide if I start in April running into me or what. But it will be particularly useful to my St. Augustine students. There's a particular reason I'm having it in person as well. Okay. So you get at me now. My capacity is actually 40. I'm trying to expand to 50. I'm not sure if this room could hold 50 people, but I'll see according to the numbers. But definitely it is extremely limited. I think I already have 40 St. Augustine here. So if you say 30 to 40, you'll sign up, then well, no one else could sign up, right? But there were about 20 something students who wanted to do the OSCE course as well, out who didn't want to do the MCQ. And I told them, well, if I have space, I'll allow them. So you'll have to get at me for that as soon as possible. Good. So that should be all. No questions, queries. Let's begin. Today, I don't even want to tell you all today going to be short because it never is. But anything that is not half nine to me does seem okay now. It seems better than the first time, but we'll try to go for the half eight today, right? Because it's only like 4 or 5 topics and they're pretty short. So we'll see. Okay. Um, this 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 up on my screen here. This up on my screen here. Right, cool. Right, good afternoon, everyone. Good afternoon again. You all see the screen?
Yes, we are.
Right. Sure. Thank you, Julian. Thanks, Celine. Hi, good afternoon, everyone, and good evening, Melina. Sorry for not acknowledging your comment. Good evening, Melina. And everyone else, good evening. So yeah, you all know the drill. So we'll be doing pleural diseases, adds pulmonary embolism, a little bit of acid base disturbances, and I think an interstitial lung disease. Yeah, keep on forgetting that one, but that one is important. So let me look. Should have thought about this before, about the order of the questions. Didn't think about that before. Okay. All right. Okay. So we'll start with this. All right, guys. So welcome everyone. Welcome. We'll start one time. I'll take answers to number 12 in the chat, right? So answers to number 12 in the chat, please. Answers to number 12 in the chat, please. Right, fantastic. That's number 12. So a couple C's, mostly B's. Good. Good. We'll do. Okay. Answers to number 10, please. Answers to number 10 in the chat. So the question is up here. The question is on the top page, and the answers are here, right? Sorry about that. They're on separate pages. But answers to number 10. Answers to number 10 in the chat, please. Okay, good, good. So you have many different answers. So you have something to teach there. Right, so that's number 10. Right, answers to number 11. Answers to number 11 in the chat, please. Answers to number 11 in the chat, please. Okay, what is this? What is this patient's most likely diagnosis? Good. Which is a subtype of what? A subcategory of which interstitial lung disease? Yeah, that's correct, Julian. So it is a ILD, but which category of interstitial lung disease? Yeah, good, William. So a hypersensitivity pneumonitis. Good. So we'll go through that. Really and truly, they hardly ever test ILDs in a plethora of ways, but I'll go through and show you all right. Um, is in and of itself can be a very vast topic, but from a academia MBBS point of view, is pretty simple. Okay, and answers to number 9, please. Answers to number 9 in the chat, please. So yeah. Answers to number 9 in the chat, please. Okay, great, fantastic. So we do have a couple concepts to clarify. Um, so that makes me happy. So let's get to teaching. Thanks everyone for answering. You are fantastic. The participation this year has been just whoa. Keeps me going, man. It keeps me going. All right, cool. Let's see this thing here. So you went to pneumonia. Guys, I had an error. I had an error, right? In the MCQs when I was telling you all about the curve score of 0 + 1, it's a macrolide plus amoxiclav, right? I think I said either levofloxacin versus ciprofloxacin. Granted that the question can come that way as well, where they give you two fluoroquinolones. The options would have been between ciprofloxacin or azithromycin plus amoxiclav, right? That is more appropriate, a macrolide plus amoxiclav. Remember, I told you all there was this question where the patient had a curve score of 1, and the options were between ciprofloxacin and two drugs. And usually we would do monotherapy with a fluoroquinolone. But in that case, we remember that ciprofloxacin doesn't have isn't effective against strep pneumo, so it's not a respiratory fluoroquinolone. So in that case, you would have gone with the azithromycin plus amoxiclav, right? So that made a little more sense. Good thing I was scrolling through there. Okay, good. TB was okay. Lung cancer was okay. Scoliosis, I think, should have been okay. All right, so we'll start off with the first question with pleural effusions. All right, good. Just making sure you all seeing the screen, right? Actually, let me draw for this. Never taught pleural effusion how I actually wanted to. So now that I have this advent of drawing, I can teach it how I want to. Let me actually draw for this. All right, good. All right, thanks, Anton. You seen the paint screen as well? Seeing me drawing here and stuff? Right, good. Right, good. Okay, so good afternoon, everyone. Today is Respiratory Medicine Part 2 and our final lecture on respiratory medicine. Give me 1 second, someone just message me, and it is Dr. Victoria Ramnarine. She is my sister-in-law, really. She says she can't make it. Okay, right, guys. So welcome. Today we're doing a couple of the high yield topics plus minorities. The super. Well, actually today is actually more high yield, but the topics are shorter. If I had to look at it, because things like lung cancer, um, sarcoidosis, they lower yield, but everything here that today they're shorter topics, but they're particularly high yield, and there are particular ways how they teach how they test, sorry, these topics, all right? So welcome to our respiratory medicine course. Today, the very first topic we'll be doing is that of pleural effusions. And I've never actually taught this online how I wanted to, right? Because I never had the advent of drawing. So let's see if we could draw and make sense of this. So pleural effusions, what is a pleural effusion? So let's just say this is the patient's bronchus, trachea, and so on. This is the lung. And what we're gonna do is we're gonna do this here, right? And then we're gonna draw this. Let me use this one purple or something, right? Let me draw this here. All right. So what this is representing, this is your lung, and this here is your pleura. Now your pleura has two layers, the one on the organ that's visceral and parietal. Okay, so the parietal is this one. The purple is the parietal, the green is the visceral. So this here will be your pleural space. So a pleural effusion would be the accumulation of fluid within this pleural space. Okay, so that's a pleural effusion. That is not fluid here. Fluid here would be pulmonary edema. Okay, and they are very different in terms of how they present on your physical exam, and they are very different in terms of the pathophysiology. So what we are dealing with is our pleural effusion 2D. All right, so it's fluid within the pleural space. That's between the visceral and parietal pleura. Good. So where pleural effusion is concerned, let's think about why it happens. And when we think about why it happens, it helps determine or help it helps when we categorize it into two causes, transudative and exudative. Right? So the first one we'll do is transudative pleural effusion. And this here should help you to remember all of the causes, and I'll show you how to bring the questions. So a transudate implies a couple things, that there's a lot of fluid, way more fluid, but less protein, meaning less LDH as well, less cells, etc. So a transudative form of pleural effusion would have little protein in it. All right. So why is that? Because of the causes of a transudative pleural effusion. So let's just say that this here is the level of a blood vessel. This is the pulmonary capillaries, right? This here black thing would represent our lung, and this here would represent our pleural. Actually, let me make this a little bit different. Ah, damn. Keep on clicking things. Oh gosh, it's not right. So this is our blood vessel. This is our lung tissue. And very adherent to our lung tissue, the blue here is our pleura. Okay? So the first thing we're talking about is a transudative pleural effusion. A transudative pleural effusion occurs, and this is particularly high yield, where there is no lung injury. And that's particularly high yield to remember. There's no lung injury to cause the effusion. However, it has to do with changes in pressure. Okay? So what we could have happening would be an increase in our venous pressure, increase in our hydrostatic pressure. And therefore, if you increase your hydrostatic pressure, what starts to happen is fluid begins to leak out into the pleural space. So that's why one of the causes of transudative pleural effusion would be increased venous pressure. So the cause of transudative pleural effusion would be increased venous pressure. The other thing that could happen in a pleural effusion is that you could have increased hydrostatic pressure, or you can have reduction in your oncotic pressure. So if you have reduction in your oncotic pressure, that is things like albumin would allow the fluid to remain intravascularly. But if you lose albumin, you would reduce your oncotic pressure, and therefore, the fluid will now leak out here into the pleural cavity. So a transudative pleural effusion is that due to no lung injury, but rather pressure changes. So increased venous pressure will increase your hydrostatic pressure or reduce levels of albumin. So we call that hypoalbuminemia. And therefore, the causes of this transudative effusion would allow more fluid to leak out, but little protein, right? Because it's due to the pressure change, it's not the vessel is intact. So in a transudative pleural effusion, your pleural fluid protein count is less than 25 grams per liter in a transudate. And so other specific causes of a transudative pleural effusion would be things that increase your venous pressure. So things like heart failure, so congestive heart failure, things like constrictive pericarditis, right? You don't need to write down the causes. I think these are in the slide. Constrictive pericarditis, heart failure, and of course fluid overload states that increase your overall fluid. So patients with chronic kidney disease or anybody that's fluid overloaded, that could increase your overall venous pressure, and therefore it could lead to the fluid leaking out. So heart failure, constrictive pericarditis, fluid overload, those can lead to a transudative cause of pleural effusion. Hypoalbuminemia, so things like cirrhosis. So remember, the liver produces albumin, it makes and synthesizes albumin. And therefore, guys, in the chat, what are your true liver function tests? There are two. Your true liver function tests. Let me see in the chat. what really assesses your liver function. Remember this from ChemPath. So you get a LFT panel, you're going to see AST, ALT. So not so much the LDH, the albumin is one, but the other one would be not so much platelets, not GGT, but INR. Yeah. So these two test the synthetic function of the liver because the liver is responsible for producing coagulation factors as well as albumin. And so that's your true liver function test, even though, of course, you'll get AST, LT, LP, etc. All right. So that's just a little ChemPath. If you have to choose one, it'll be either albumin or your coagulation study, your PT-INR to be specific. All right. But we talk about that in GI. That's just a by the way there. All right. So cirrhosis leads to reduction of the albumin being made and things like nephrotic syndrome. So nephrotic syndrome, what's going to happen in nephrotic syndrome? You're going to be peeing out all of your albumin. You're going to have a proteinuria with a hypoalbuminemia and a periorbital edema is how it usually manifests in pediatrics. All right. That triad of edema, hypoalbuminemia, and proteinuria more than 3.5 grams. Remember that? Yeah, good. I ain't teaching no peds today. So cirrhosis, nephrotic syndrome, and if you can't absorb protein, so malabsorptive states. All right. So for transsudative pleural effusion, it's due to not lung injury, but rather pressure changes, increased venous pressure, reduced oncotic pressure. So increased venous pressure in heart failure, constrictive pericarditis, fluid overload. Hypoalbuminemia would reduce your oncotic pressure, cirrhosis, nephrotic, malabsorption. And so overall, your protein count will be low. It will be less than 25 grams per liter. Now, there are other causes. And honestly, I can't tell you that I know the pathophysiology offhand. So just remember that the other causes of a transsudative pleural effusion, apart from increased venous pressure, right, hypoalbuminemia, the two other ones I want you all to remember would be hypothyroid, and this can cause both a transudate and exudate, but it is more commonly associated with a transudate, hypothyroidism, and of course, Meg's syndrome. Right? So Meg syndrome is the patient has a right. We actually had a patient with this when I was in cardiology, but I now started house officership. A right pleural effusion plus an ovarian fibroma. Okay, so these two are also particularly high. So that's your causes of a transsudative pleural effusion. It is not due to lung injury. It is rather due to your pressure changes. All right. So know all of the causes of a transudate, and it is less than 25 grams per liter. Okay. So that's transudate. Good. So that's how a transudate works. So now you'll never forget what is the difference between transudative and now let's do exudative. Oh my gosh. This thing, right? Exudative, right? So a exudative pleural effusion, right? So in an exudative pleural effusion, it is due to lung injury, and that helps clue you in to what could cause exudates. So again, in this one, however, because you have lung injury, this is a blood vessel where you're going to have here. You're going to have breakages in your blood vessels. So you're going to have leaky vessels, and let me just erase this. You're going to have leaky vessels, and you're also going to have a leaky lung. Okay, pleural space is going to stay the same. So this is an exudative pleural effusion. What happens in this case? You have lung injury. You have vessel capillary injury at the level of the lung tissue. And therefore, everything now will seep out. So not just fluid, everything else. So protein go in, LDH go in, as well as a fluid. So that means in an exudative pleural effusion, what you have is high fluid, yes, but you also have high amounts of protein and high amounts of LDH. Okay? And so for exudative pleural effusion, your protein content will be more than 35. So transudate is less than 25. exudate is more than 35. All right. So therefore, what could mash up the lung? Well, the easy way to remember the causes of exudative pleural effusion is infection, inflammation, and malignancy. Okay, so things like pneumonia, tuberculosis, all the infections in the world. Inflammation refers to things like rheumatoid arthritis, lupus, so your autoimmune diseases, and of course malignancy being all types of bronchogenic cancers. Okay, so an exudative pleural effusion, you have lung injury, all your protein leaks out into the space, and therefore you have a high protein count. And what could injure the lung in an exudative pleural effusion? Infection, inflammation, malignancy. And so that, therefore, is the difference between a exudative and a transudative pleural effusion. And that's the most commonly tested point. You just need to know the causes of them. So we said we have transudate, and we said the transudate is less than 25 grams. So that means if you do a fluorocentesis and you get a transudate, you get a protein count of your pleural fluid less than 25, you can automatically say it's transudate. If it is more than 35, you can automatically say it is an exudate. But then there's this range here, 25, 35. What do you do there? So in any patient with a fluorocentesis, so to diagnose that, we'll talk about the workup and so on. I'll talk about presentation, etc. But let's talking about what MBBS tests. Seeing something in the chat just now. Right. Oh, yeah. Daniel is asking what. Okay. Yeah, Daniel. Right. So that's where now, if you have 25 to 35, this is where this thing called Light's criteria is applied. Light's criteria is applied here. And what Light's criteria have determined, Light's criteria, if any of Light's criteria are positive, just one of them, if all of them, but if any one of Light's criteria is positive, it means that it is an exudate. Okay? That is the rule of Light's criteria for your protein count between 25 to 35. All right? So how do I remember? Oh my gosh, let me X out and reopen. I shrink the screen again and I just know how to thing it, how to get it back. So let me reopen this here. Oh gosh, guys, I shrink the screen and I don't know how. So, oh, there you go. Guys, I'm not technologically inclined, right? Good. So for Light's criteria is applied where your pleural count is between 25 to 35 grams per liter, and it says if any of them are positive, it's an exudate. So what is Light's criteria? How do I remember Light's criteria? I do this. I do PF over SF, then I do PF over SF again, and then I just simply have a PF. So it's PF over SF, PF over SF, and PF. All right? So if your pleural fluid over serum fluid protein is the next word. Pleural fluid over serum fluid, LDH. And if your pleural fluid only, LDH, is more than a certain value, then it's an exudative type of pleural effusion. So it's PF over SF, PF over SF, PF. So protein LDH, LDH is what comes next. And pleural fluid over serum fluid protein more than the value here is 0.5. My gosh, that is not looking like a good 5. 0.5, right? The value here is 0.6, and pleural fluid LDH I remember as 0.666666, right? So let's add on our next 6 so we're not too devilish wrong here, right? So it's pleural fluid LDH more than 2/3 the upper limit of your lab, okay? So if any of these criteria are met, then it becomes an exudate. All right, so this is the rule of Light's criteria right here. So we know our causes of transudates, we know our causes of exudates if there's obviously more than 35 or less than 25. But if we have a protein count in between, then we have to apply Light's criteria and determine whether or not it's an exudate. So how MBBS brings it is sometimes they actually want you to calculate and apply Light's criteria. Other times they simply tell you what the protein count is, and it's obviously a transudate or obviously an exudate based on the pleural fluid plural, plural fluid protein content only. All right? Good. So is that concept clear, everyone, about the difference between transudate and exudate? Do I have any questions there? We need to remember that forever and ever because that's the most common way MBBS tests pleural effusion. Are we clear, guys? Fantastic, right? So we know the difference and we know how to apply Light's criteria. So let's say you have, just check the chat. Anton?
Yeah, Seth. The 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 things that you just wrote, the PF over SF, protein LDH,
Yeah.
those those are values that we would be given, and then we have to
So
work on.
okay, so sometimes they will give you a pleural fluid analysis. So sometimes they will do something like this. They will tell you the patient has a pleural fluid, tap a fluorocentesis done, and they give you a protein, and the protein, like that says 27, and then what they'll do is they'll give you an LDH, like just say the LDH. I don't know what LDH range is for this thing, but like just say it's 10 for simplicity's sake, right? And then they'll give you a serum, right? And they'll also give you glucose, and we'll talk about that. They'll also give you pH and so on. And then they give you a serum and they tell you the serum is, let's say, how to do this. Let's say 50, and let's say the LDH is 14. Good. And so therefore now you can apply like criteria, and so the pleural fluid over serum fluid protein is 27 over 50, that's more than zero point 0.5, that's about 0.54. So that's already like criteria is met. So this is an exudate. Or if you do a pleural fluid over serum fluid LDH, it should be more than zero point 0.6. 10 out of 14, yep, that's 5 on 7, that's point something, something, something. So sometimes they give you a pleural fluid sample analysis with bloods, and you have to calculate and apply Light's criteria like that. Yeah, Anton?
Okay, so I got it.
Yeah, gotcha. Cool. Right. Um, Good. Any more questions, guys? I think that was it. That was all the questions I saw there. Good. All right, nice. So now this thing about pleural effusion and how it presents is also particularly important because they actually did have a patient with a pleural effusion 1 year, was a stable patient with a pleural effusion that came for MBBS. All right, so pleural effusion findings. So this is the pleural space. All here is a fluid, 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 fluid within your pleural cavity. And so therefore, what is going to happen? A patient will obviously have things like dyspnea and so on if it's real bad, right? So common symptoms of respiratory distress. That's fine and understand. But what's more important is the findings on exam. So you have one set of fluid here. What's going to happen when the patient tries to talk and you put your hand on the border of your hand along the respiratory areas? And in my OSCE course, I talk about where you place your hand and so on. But in this case, your tactile vocal fremitus would be reduced, right? So you have a reduction in tactile vocal fremitus for a pleural effusion. Whereas if you do a percussion, what's going to happen? You're not going to be able to get up a resonant note because you're percussing against fluid. So you'll have a stony, a very serious stony delta percussion. And if you ever percuss, guys, if you ever have a patient with a pleural effusion and what just press it, you'll never forget what stony dull to percussion means, right? It is literally like stone. So you have reduction in tactile vocal fremitus with stony dull percussion, and of course, when you auscultate, you'll have reduced breath sounds. Okay, so those are your exam findings. On exam of a pleural effusion, it's a reduction in your tactile vocal fremitus. This helps differentiate it from a pulmonary edema. A pulmonary edema where sound is conducted through that fluid in the lungs, right? In a pulmonary edema, you have increase in your tactile vocal fremitus. All right, so that's a key differentiating factor there. So for pleural effusion, we have a reduction in our tactile vocal fremitus, stony dull on percussion, and reduction in breath sounds. So that's our exam findings, particularly high yield. So If we suspect a patient has a pleural effusion for one cause or the other, the main thing we have to see it on is a chest X-ray, and we know our chest X-ray gives us our meniscus sign, right? Just Google some images. I don't think I have it in my guide. Just Google some images of a pleural effusion. You have blunting of the costophrenic angle, and so on, right? Blunting of costophrenic angle, etc. So you do your chest X-ray, and it's obviously a pleural effusion. What's your next best step? Of course, your next best step would be to do a pleural tap, also known as a pleurocentesis. And if they want to be less specific, they will call it a thoracocentesis, right? So this is both therapeutic and diagnostic. So it's diagnostic plus therapeutic. So that is where you take a needle, you insert it into the pleural space, right? So this is how you diagnose. And once you do that, you're going to send the sample now for assessment. Okay? So we said transudate less than 25, exudate more than 35. And then Light's criteria will help us determine. So if anyone is positive for Light's criteria, then it's an exudate. However, if all three are negative, then it's a transudate. Okay? So that's the role of Light's criteria there. So let's say you have a transudate, you automatically think about what the cause is going to be, right? And the cause we said would be one of the things like fluid overloaded states, etc. But what about if you get an exudate? Can anyone tell me we get an exudate on our sample? What's our next best thing to assess? It's an exudate based on the protein count. It's an exudate based on light criteria. It doesn't matter. Fact of the matter is it's an exudative pleural effusion. What is our next best? What in within the pleural fluid is most important? Fantastic, William. Right? So good option, Mark, but the next best thing is actually a glucose. So once we have an exudative pleural effusion, we need to know our glucose level. All right? So for an exudate, we get an exudate, we're going to check the glucose level. And if your glucose level is high, is one set of things it could be. And if it's normal, sorry, if it's low, my bad, guys. If it's low, hear me talking shippiness. If it's normal, it's another set of things. So if you have an exudative pleural effusion, we said it could be infection, inflammation, malignancy, but we do a glucose count. There are other things a normal exudate could be. So if it's normal when we do the glucose count, if the glucose count is normal, it can also be due to a chylothorax, right? And a chylothorax would have high triglycerides within the sample. It could be due to a hemothorax, because remember, hemothorax is blood within the pleural space as well. And of course, you'll have red blood cells. Or um, it could be due to, it could be due to a pancreatitis, right? So if you get an exudative sample, you want to check the glucose level, and if your glucose level is normal, it's going to be chylothorax, hemothorax, or pancreatitis, and pancreatitis will have, of course, amylase. So that will be the cause of a pleural effusion in that case. However, for the exudate, if you do a glucose sample, you assess the glucose of the pleural effusion fluid, and it's low, it can be MEAT, right? So it could be M, E, A, and T. And so for the T, it's tuberculosis. For the A, it is autoimmune. So that'll be rheumatoid arthritis, SLE. For the E, it'll be empyema. And for the M, it'll be malignancy. So it could be one of these things with with a low glucose. And how we could tell, so the malignancy would have abnormal cells. So you do cytology, and it could tell you, right? So that is that for the malignancy. For the TB, we could test for our acid-fast bacillus. That could help us there. For the autoimmune, while we do full autoimmune panel, we could do ANA, rheumatoid factor, etc. And of course, for our empyema, we'll have a high amount of white blood cells. So empyema is where you have infection and pus within the space. All right. So low glucose could be empyema, rheumatoid arthritis, lupus, TB, or malignancy. So it could be MEAT, malignancy, empyema, autoimmune, TB. Normal glucose will be chylothorax, hemothorax, or amylase to be specific. All right. And of course, other causes of infection, inflammation, and malignancy. Okay. So that is how we work up that for exudative. And then lastly, for pleural effusion is how we treat it. And there are four things I want you all to remember. Treatment could be fluorocentesis. So you just take a needle and aspirate. Okay. So this is really reserved for the patients with mild symptoms and non-recurrent pleural effusions. Okay. The next thing we could do is a chest tube. Now, in Mount torpedoes do chest tube for everybody, but really and truly, chest tube is really only indicated if the patient has an empyema due to the pleural effusion or hemothorax causing the pleural effusion. All right, but in real life, we do chest tubes if we find the pleural effusion is not getting better. The other option is what we call video assisted thoracoscopic surgery, so video-assisted thoracoscopic surgery. That's beyond the scope of this lecture. But what is within the scope of this lecture is for patients with recurrent pleural effusions, we can do a pleurodesis. So pleurodesis is where you obliterate the pleural space, right? So we basically are going to obliterate the pleural space either by sticking the visceral and parietal together, and for this, we can use talc, which is the material in gloves, or even doxycycline is used in some cases. All right. So these are treatment options. So pleurocentesis, if you're a patient now coming with a pleural effusion, you drain it, you're not sure what's the cause, but it is causing a decrease in the SpO2 and so on, we'll do a pleurocentesis. If now the pleural effusion is worsening, reoccurring, we can do a chest tube. If it's still refractory and always reoccurring, then we could do video assisted thoracoscopic surgery. And if it's recurring in cases of things like malignancy, then we may opt for a pleurodesis. All right, I think I saw something in the chat. Yeah, right?
No, I'm just
Good
giving
son.
that option. No worries, sir.
Yeah, sure. Right? So those are your treatment options for pleural effusion. Something I was going to say here. Uh, what was I going to say that was particularly important here? Damn, I can't remember what I was going to say here. All right. Well, yeah, that should kind of cover it. That should kind of cover it. Okay. So that's pleural effusion. Just as a by the way, if you want to know what an empyema is, so this is your lung, right? This is your pleural fluid here. This is your lung. This is a pleural space here, right? This is your lung, and this is your pleural space here again. So in empyema, what happens is first and foremost, your pleural effusion is due to a pneumonia, right? So we'll put here bacteria, one set of bacteria, and that bacteria led to lung vessel damage, so it would lead to an exudative pleural effusion. And what happens in that case, that pleural effusion, oh my gosh, I just erased my whole damn thing, right? That pleural effusion will be called a parapneumonic effusion. And in this case, where it's just a pleural effusion in the setting or due to pneumonia, it's called an uncomplicated parapneumonic infusion, right? What can happen though is that this now infection here, the bacteria and so on start to leak into the pleural space. And so now when you have bacteria in the pleural space, it becomes a complicated parapneumonic effusion. Parapneumonic effusion, that's too big a word to write out. And then what could happen is this bacteria and so on could now progress until it becomes what we call loculated. And this loculations with things like your white blood cells, your bacteria, etc. Once it are pus with loculations, this is called an empyema. Okay. So that's just that. And an empyema, we said, would be an exudate. So empyema would be an exudate, and it would have low glucose, and it could do cultures and look at the types of cells. Okay, great. So that is pleural effusion. Any questions on pleural effusion, guys? Are we clear? Transudates, exudates, cause, treatment, workup, exam findings, etc. Right, fantastic. So that's pleural effusion. So let's now go to the guide. So I never actually got to teach it like this, and I think it turns out way better because the guide I just used to talk it through and never really could illustrate. It's stony delta percussion. It can cause a mediastinal shift, etc. So we know transudates, exudates. We know when to apply Light's criteria. Plural, right, right, right. Good. We know the causes of transudates, the causes of exudates. This image here shows you what I was talking about in your Oxford. So when we do glucose, if it's low, it could be meat, malignancy, empyema, autoimmune, or TB, right? pH, a low pH also is the same thing as meat as well. Um, LDH, well, we spoke about infectious causes, inflammation, etc. Because a high LDH would mean exudate. Good, and amylase, we said, would be pancreatitis or esophageal rupture is another one. All right, so we know the different causes and so on. So, guys, takeaways. What do they bring? So when they bring in pleural effusions for your exams, most of the times it's to be identify which is it not, which is it. And sometimes you'll have to apply Light's criteria. Other times they'll just give you the protein. And so they'll ask you which one of these is not the likely cause of the pleural effusion or which one of these is the most likely cause. And then you have to determine, is it a transudate? Is it an exudate? The options will come as 4 transudates and 1 exudate. So that's one way to know you're correct. Or you could just look at it and know what your transudates and exudates are. So usually most times it's a process of elimination. For me, I don't even read the question. I just eliminate all the 4 that are similar and know that the odd one out is my answer. Right? So that's that. But big takeaway, know all of the causes of pleural effusions. Great. All right, so that's a particularly high yield topic there. Good. Next, we will do ARDS and we'll do ARDS probably using the guide. So acute respiratory distress syndrome. So we had no questions on pleural effusion, so we go straight into acute respiratory distress syndrome. So acute respiratory distress syndrome is, as the name implies, it is acute. It is respiratory, meaning it is due to pathology within the lungs and not the heart. It is distress, meaning the patient is breathing abnormally, and so their oxygen levels are going to be low, even if they are on oxygen. And it is a syndrome. That means it is not a direct diagnosis. That means it has underlying causes. All right. And I remember I was going to tell all you about pleural effusion is to treat the underlying cause. Right. So I'm putting it in the chat. The most important thing about a pleural effusion, guys, is to treat the cause. All right. Because if you don't treat the underlying cause, the pleural effusion will keep on recurring. So that's what I said I forgot to tell you. So for acute respiratory distress syndrome, acute respiratory distress is how you remember Berlin's criteria. It's acute. It is due to lung pathology, not heart pathology. It is distress, meaning your PaO2 and your FiO2 doesn't matter. It will have a reduction in your PaO2 ratio. Okay? So ALS happens because of damage to type 1 and type 2 pneumocytes. Let's just, as I'm drawing today, let's just keep in the spirit. So your type 1 pneumocyte, so this is your alveoli here. This is your alveoli here. So your type 1 pneumocyte is basically your lung cells, right? So if you have damage to these lung cells, what is going to happen? You're going to have breakages here. I'm going to cut it up, cut it up, cut it up, cut it up. And therefore, what is going to happen? Well, in this case of acute respiratory distress syndrome, what is going to happen is that the blood is going to leak in here because you have damage to your type 1 pneumocytes, right? Whereas if you have damage to a type 2 pneumocytes, it's the same kind of concept. Type 2 pneumocytes help produce surfactant. And if your surfactant level is reduced, your alveoli are going to become smaller. And so the ultimate effect is here, in this case, for this is type 1 pneumocyte destruction. This is type 2 pneumocyte destruction. In type 1 pneumocyte destruction, fluid is going to accumulate inside here. And here, the alveolar is small, okay, for type 2 pneumocytes because they have atelectasis. So ultimately, what is going to happen in acute respiratory distress syndrome is a VQ mismatch. Ventilation perfusion mismatch. What does that mean? Ventilation means oxygen coming into the lungs. But if you have one set of fluid here, can this alveoli be filled with oxygen? No, it can't. And so even though the blood, because this is blood running through, this is a blood vessel, even though blood is flowing through to receive the oxygen, you're not adequately ventilating. So that's one way you have a ventilation perfusion mismatch. And again, lung collapse, atelectasis, right? You have atelectasis. Can oxygen fill up this smaller alveoli? No. You have reduced oxygen despite retaining your blood flow. So therefore, you have a ventilation perfusion mismatch. And we said the other day, ventilation perfusion mismatch leads to a hypoxemia, right? It means you're not getting enough oxygen in the blood. And so therefore, this would lead to a type 1 respiratory failure. So acute respiratory distress syndrome leads to a type 1 respiratory failure, and therefore your carbon dioxide levels are usually normal in ARDS. All right, so that's a little bit about the pathophysiology. So what could happen is that you could have direct lung injury, so you could call it direct lung injury, or you could have indirect lung injury. Either way, both of these things are going to happen. Type 1 and type 2 pneumocytes are going to be damaged. All right. So the causes are direct causes like pneumonia, aspiration, jogging certain toxins like smoke and so on. Or you can have indirect causes. Sepsis could cause a lot of inflammation and therefore damage the lung cells. Trauma, TRALI, which is transfusion related associated lung injury. So blood transfusions. So anything that causes severe inflammation can damage the type 1 and type 2 pneumocytes, severe and widespread inflammation. So pancreatitis as well. All right. So that's a direct and indirect causes. Learn them well. This is a pretty comprehensive list, and know that they can all cause this syndrome called acute respiratory distress syndrome. All right. So, guys, the most important thing about ARDS or ARDS is this criteria and to understand ARDS criteria. Okay? So, this is called the Berlin criteria, and this is what you need to make a diagnosis of ARDS. One, the PaO2 FiO2 ratio has to be less than 300 to be considered acute respiratory distress syndrome. What that means is the partial pressure of oxygen in the blood is less than 300, even though you have the patient on inspired oxygen. The ratio is less than 300, even though the patient is on inspired oxygen. So that means that the blood is not being properly oxygenated despite oxygen therapy. So that's your PaO2 FiO2 ratio, and it requires a P positive end expiratory pressure to be more than 5. All right, so that's basically on oxygen. So that's one. This PaO2 FiO2 ratio for ARDS is what also allows you to categorize ARDS into mild, moderate, and severe. And this is particularly high yield as well. So a PaO2 FiO2 ratio between less than 300 but more than 200 is mild ARDS, 100 to 200 is moderate, and less than or equal to 100 is severe ARDS. And so your PaO2 FiO2 ratio helps determine mild, moderate, and severe ARDS. And so therefore, to diagnose ARDS, one of the investigations you need would be an arterial blood gas to get your PaO2. Good. The other thing about Berlin criteria is the timing. You need your symptoms to be acute respiratory distress syndrome. Acute, that is within 1 week of a known clinical insult or worsening respiratory symptoms. So it is within 1 week of insult. That makes it acute. Not 2 weeks, not 3 weeks. It is within 1 week. So that's the timing. The other thing for ARDS is the chest imaging. On your chest imaging, you must have bilateral pulmonary infiltrates that is not due to effusions, lung collapse, or nodules in the case of things like cancer, miliary TB, etc. So your opacities is literally edematous in nature. It is infiltrates that you see. It is not effusions that you see. So it is bilateral opacities not explained by effusions, lobar collapse, or nodules. This is on chest imaging. And therefore, your other investigations you would need would be a chest imaging with either chest x-ray or a CT scan. The last thing to make odds is that it has to be respiratory, acute respiratory distress. It cannot be explained by cardiac causes of pulmonary infiltrates. And therefore, what you would need would be to rule out cardiac causes. And in the case of acute respiratory distress syndrome, an echocardiogram might be necessary if you don't have an identifiable cause, or something like BNP, because BNP suggests heart failure if it is elevated. We spoke about heart failure and the pro-BNP levels. And the other thing we can say, and this used to be part of your criteria, this is the modified Berlin and the most up to date. The other thing to add to that would be, it's not allowing me to do it on the screen, would be pulmonary capillary wedge pressure, which we would have spoken about. That is where you have your right heart catheterization. So you can do right heart catheterization. It's kind of extreme to do that, to say it's not odds, because usually an echo would suffice. But that would be the other investigation of choice that can be used to, to diagnose acute respiratory distress syndrome. Okay. So your billing criteria, you need to know and comprehend and understand 100%. This is the most important part of ARDS. Understanding Berlin, understanding its PaO2, FiO2 less than 300, mild is 2 to 300, moderate is 1 to 200, severe is less than 100 for that ratio. It has to be within 1 week. You have to have bilateral infiltrates that are not effusions, it's not lung collapse, it's not nodules, it's bilateral infiltrates on chest imaging, and those infiltrates are not explained by cardiac failure. So your echo rules out heart failure, your BNP rules out heart failure, your heart catheterization rules out heart failure. Notice spirometry is not used to diagnose ARDS. Spirometry is used to help determine or differentiate between obstructive and restrictive lung diseases. So in your homework, you'll see that answer that question, and those of you who haven't done it, well, there goes your answer. All right. So these are the investigations based on the criteria that we can use to diagnose acute respiratory distress syndrome. Now, on your guide, I did include this thing that is being researched. I'm not sure how popular it is within the Caribbean, but this is the new global definition. And the difference between this and the Berlin criteria is that your chest imaging for Berlin criteria is only chest X-ray or chest CT. But for your global definition, this is new updated definition of ARDS. If you see pulmonary infiltrates on a lung ultrasound, yes, you can actually see that. That forms part of your global definition. So you can use a bedside ultrasound to determine if they have infiltrates. And also, if you see the patient's SpO2 is less than 97%, that is hypoxemia or SpO2 less than 97%, with a PaO2 with a SpO2 FiO2 ratio of less than 315, that is also included in this new definition. Does MBBS test this? I can't say I've never seen this being included in MBBS. I really can't tell you how much it is in the Caribbean, but this is being accepted more commonly worldwide for two reasons. They're saying, well, SpO2 is obviously the easier thing to do and obtain. You just put a probe on the finger. So why not use it to help us determine odds? And of course, a bedside ultrasound can be done at the bedside and you could look for pulmonary infiltrates. So it makes it easier to diagnose acute respiratory distress syndrome at the bedside. And that's the reason for this definition. So I've just included that just in case it pops up. But for sure, what you have to know is the Berlin criteria, understand the investigations, the criteria themselves, mild, moderate, severe, and how you go about actually diagnosing acute respiratory distress syndrome. It's specific criteria, it's evidence-based medicine. All right? Are we clear on will and criteria explanation, guys? Nope, Kadima. Spirometry is not used. This is your Boolean criteria, right? So you're not going to see anything about spirometry here. Spirometry is for your obstructive and restrictive lung diseases. It tells you about your forced expiratory volume, your forced vital capacity. It tells you about the physiology of working of the lung. Is it restrictive? Is it that you cannot inspire? Is it obstructive? Is it that you can't exhale? And so spirometry is not used to diagnose acute respiratory distress syndrome. You're welcome there. All right. Good. Any other questions, guys? Are we clear on Boolean criteria? I don't know if it's yes, no. Okay, great. Nice, because that's the most important part about odds. Um, you have these three stages here. And now I'm going to just tell you all a little bit about treatment of acute respiratory distress syndrome. This is lower yield, but it is also evidence-based. And in my research, um, I saw that there are things that they can bring that I haven't seen as yet. So when it's talking about treatment of ads, how I remember the concepts is that you want to sedate, ventilate, and dehydrate, right? Plus dehydrate. That's how I remember the concepts about managing or treating acute respiratory distress syndrome. Sedating the patient, ventilating the patient, and dehydrating the patient. So you're not actually going to dehydrate and starve them. What this is judicious fluid administration. And that's because you don't want to worsen that pulmonary edema. Okay, so you're going to sparingly use fluids. That's called judicious fluid administration. Yeah, the same phrase you use for flail chest, judicious fluid administration, right? Ventilation is critically and it is the mainstay of treatment for ARDS. So it is mechanical ventilation, right? Mechanical ventilation with positive end expiratory pressure. So it's mechanical ventilation with PEEP. This is your answer. Your patient has ARDS. What are you going to do? Mechanical ventilation with PEEP. Most times is the answer. Make sure you have fluid, judicious fluid administration, and well, of course, the patient is going to be sedated. All right. Now, if these things don't work, they these things, the other thing about this is that these things are proven to reduce mortality in ads, right? So they reduce the mortality, even though ads itself has a poor prognosis, as 40% of patients die. But those things, so it's sedate, ventilate, dehydrate. In that case, however, if your PaO2 FiO2 ratio is still bad and it's, let's say, between moderate and severe. Now some sources say less than 100, other sources say less than 150. So despite your ventilation with PEEP, despite your judicious fluid, etc., if your PaO2 FiO2 ratio is still giving you moderate to severe ads, right, then your next step could be to add on a neuromuscular blocker. Neuromuscular blockade helps. Can't tell you the pathophysiology of that, I'm sorry. If this doesn't work, your next step is prone position of the patient. Okay, so when you place the patient prone in a prone position, you're gonna the dependent areas where you have dependent atelectasis in a supine position. When you place them prone, that is lying on their tummy with the ventilation, it also helps to properly ventilate the lungs, right? So prone position is reserved for severe ads. Okay, less than 100 or less than 150, depending on the source. All right, so let's remember this is a particularly high yield point. If on your mechanical ventilation with PEEP, the patient is still in moderate to severe ads, then you have to upscale, and that upscale could be either adding a neuromuscular blocker or placing a position in a prone position. And these two also reduce your mortality in ads. Okay, that's that. And then there's this new advent that I saw. Like we don't have that here. It's VVMCO, which is Veno Venus. Let me see if I remember what it stands for. Veno Venus. The E is extracorporeal. Okay, I need to Google this, right? So Veno Venus, VV. It was pretty cool. I've never seen this. I don't even know if you have. Veno-venous extracorporeal membrane oxygenation. This is reserved for ARDS that is refractory on ventilation, refractory in prone position, etc. Basically, it's like dialysis, but for your lungs. Pretty cool. Um, let me see. Signal, let me click here. Okay, there you go. Right, so basically what you're going to do is the machine is going to pull the blood out of the right side of the heart, pump it into this machine that actually oxygenates the blood. So it pulls it out of your your inferior vena cava, which is deoxygenated blood, transmits it to a machine to be oxygenated, then pushes it back into your heart through your superior venous cava. So that is pretty awesome piece of technological advancement there, right? I don't know if it'll be tested. Doubt it will be, but I thought I would bring it to your attention that it exists. I do not know anything about it, never seen it, but just know that it is reserved for refractory ARDS despite every single thing. But that VVM core has no reduction in mortality, right? It's not evidence, doesn't say that it shows reduction in mortality if you do that. All right? Cool. Yeah, it's super cool, Jody. It's super cool. I've never seen it. Don't know when that will reach to Trinidad. Don't know if it ever will. But yeah, so they actually do it in America. So that's that. Okay? And that's ADS. That is acute respiratory distress syndrome, guys. So the treatment is particularly high yield, mechanical ventilation with PEEP. You're aiming for PEEP for PaO2. So these values you could learn off. PaO2 55 to 80, SpO2 88 to 95. You're adjusting the fraction of inspired oxygen, you're adjusting the PEEP. You don't want them too tachypnic or too bradypnic, right? And remember, prone position can help if the patient is still in severe ARDS despite mechanical ventilation with PEEP, and make sure we use the distress fluids and we don't ever use steroids for ARDS. Okay? But the most important thing, guys, is this and in understanding and interpreting this. All right? Cool. So any questions on acute respiratory distress syndrome, guys, or pleural effusions? Are we clear on those things? We clear on transfer dates, exit dates, diagnosing, workup. We clear on building criteria. We clear on what investigations we use, etc. Okay, fantastic. Right, and the last topic before we answer questions and take a break would be interstitial lung disease. Right, so this one is mostly going to be I don't think I could draw for this. Right, so interstitial lung disease is, as the name implies, within the interstitium of the lung, yada yada. We're not going into too much pathophys. This is what they bring. So the cause of ILD, the cause of interstitial lung disease, can be remembered by this mnemonic that I learned from Paul Bullen many moons ago. Shit-faced, all right? That is sarcoidosis, hypersensitivity reaction / histiocytosis X, idiopathic pulmonary fibrosis, tuberculosis, fungal infections, asbestosis, collagen vascular disease, etc. Right? It's self-explanatory. So just learn off this mnemonic, guys. What I want to point out here is that remember that sarcoidosis causes interstitial lung disease, and so that is particularly high yield because some of your patients for OSCE tend to have fine and inspiratory crackles, and it is due to fibrosis in sarcoidosis. All right. So when you get your OSCE, interstitial lung disease is one of the common conditions. It's more common in OSCE, less common in your MCQs. And just know that the finding would be fine and inspiratory crackles. So when you get your respiratory exam, to my St. Augustine students, 100% certain you are getting a respiratory exam. Okay, so practice it from now and learn it well. I will tell you what the possible differentials are when that time comes. But just know that fine and inspiratory crackles, interstitial lung disease, right? So you're thinking about fibrosis. Good. So sarcoidosis, hypersensitivity reactions, and the most common cause of interstitial lung disease is idiopathic fibrosing interstitial pneumonia. That's the new name for idiopathic pulmonary fibrosis. Okay. So overall, those are the causes. The other thing that they like to bring in MCQs would be the drugs actually causing pulmonary fibrosis. And there's this nice mnemonic that I made up myself. It's amiodarone, methotrexate, bleomycin, busulfan, nitrofurantoin, and sulfasalazine, AMB, BNS. Now, AMB, BNS are the most commonly tested causes of or drugs, commonly tested drugs causing pulmonary fibrosis. All right, so let's learn them off. All of these drugs can cause pulmonary fibrosis. So that brings us to the common patients for your OSCE. This was my patient for my OSCE. It's a middle-aged to elderly female, and the elderly female has a Z-thumb deformity. She has some swan necks and so on, and she had some that what we just mentioned, fine and inspiratory crackles. Can anyone tell me what is this patient's diagnosis? Rheumatoid arthritis. So the question the examiner asked me would have been, so all right, why does a patient with rheumatoid arthritis have fine and inspiratory crackles? What's the answer to that? Fantastic, Farhan. I told Verana that question personally when she came to my class before, right? So it's two reasons. It's the fact that rheumatoid arthritis itself can lead to interstitial lung disease and fibrosis. And also, mainstay of treatment for rheumatoid arthritis is methotrexate. So patients with rheumatoid arthritis can get interstitial lung disease because of the disease process. And also, when you put them on methotrexate, it can also cause some idiopathic, some interstitial disease and fibrosis there, right? So that was my question, and that was what got me my distinction. Simple question, easy concept. So good. So know the drugs. That's the thing about it. Know the drugs. Um, and where do we use methotrexate in gynae? As a by the way. Yeah. So an unruptured ectopic for medical management once the criteria is fulfilled. And so big takeaway. Ectopic pregnancy is real easy. It's like the easiest topic in gynae. You learn everything, methotrexate, based on your body surface area, learn the side effects, how you administer it, when you administer it. You're looking for the size of the gestational sac, blah, 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 right? I don't teach gynae, but ectopic pregnancy is going to come for your exam. Okay. Very easy topic. So get your marks there. Good. So interstitial lung disease, we know the causes, we know the drugs causing pulmonary fibrosis. And so for your investigations for interstitial lung disease, remember it's a restrictive lung disease. So if you need to know restrictive lung diseases, all of these things, once they cause interstitial lung disease, can cause restrictive lung disease. And therefore, to determine if it's a ILD, we would need spirometry in this case. So to determine the difference between restrictive and obstructive lung diseases, that's where spirometry comes into play. And for our restrictive lung diseases, our FEV, FEC is more than 70%. For obstructive lung diseases, it is less than 0.7. It is less than 70%. And remember, but anyway, I'll talk about COPD for a little bit after, right? But this is FEV, FEC more than 0.7. That's pointing towards interstitial lung diseases, all right? Your chest X-ray would show what we call reticulonodular shadowing in the case of idiopathic disease, or just some diffuse patchy infiltrates and opacifications, right? And that suggests interstitial lung disease, given your entire clinical picture fits. Okay. Our HRCT would be particularly useful because you'll see this called the honeycomb pattern, and that name is particularly high to remember to look out for in your MCQs because sometimes they do tell you honeycomb pattern on HRCT of your lungs. That's interstitial lung disease of some cause. All right. So that's that. And most of the times, honestly, the treatment is just treat the underlying cause. And if it's idiopathic fibrosing interstitial pneumonia, it's just supportive care, chest physio, give them some oxygen. So that's why it's lower yield on your MCQs because there's not really much to test about it, for at least at your level. And in real life too, right? These patients, it kind of sucks that they're going through all of this fibrosis, but you really can't do much for them. It's kind of difficult to treat. And so they hardly test these kind of concepts. But because they are so stable, they come for OSCE all the time. Okay, so look out for your patients with lung fibrosis and ILD in your OSCE. Definitely, those are the most common patients, along with COPD and some asthma. All right. What they do test, if they test it, is this concept, and this would be your E, environmental and occupational lung diseases in your shit-faced mnemonic. So this concept is particularly high yield, guys. That's the difference between hypersensitivity pneumonitis versus pneumoconiosis. So a hypersensitivity pneumonitis, also known as extrinsic allergic alveolitis, these terms are used interchangeably. Know them and learn them well. This results from the inhalation of organic allergens. That is, from things that are somewhat alive. So, if you are exposed to agriculture, or in some cases, some bird feces, then this would lead to a hypersensitivity pneumonitis. The causes of hypersensitivity pneumonitis you have to know inside out. Farmers' lung, malt workers' lung, sugar workers' lung, bird fanciers' lung, mushroom pickers' lung. Phagocytosis is another name for sugar workers' lung. It is a hypersensitivity pneumonitis. So don't get tired because it's zoosis. Don't think that is going to be a pneumoconiosis. Okay? Phagocytosis is sugar workers' lung. Now, there are other causes of hypersensitivity pneumonitis. The list is vast. Things like cheese picker and cheese worker and all of those things. So Google some more causes, but these are the ones that I see MBBS test a lot. All right. So these are due to inhalation of your inorganic allergens. It is not a pneumonia. And so bird or pigeon fancier's lung is not caused by chlamydia psittaci, which is a pneumonia seen in parrot keepers mainly. Bird fancier's lung is due to inhaling the avian proteins in the bird droppings, and that is a interstitial lung disease. That is a hypersensitivity pneumonitis. It is a extrinsic allergic alveolitis. All right. The other way they like to bring this is test it and compare it to an occupational asthma. The huge difference would be two things. For the interstitial lung disease, your chest x-ray would show the classic bilateral pulmonary infiltrate, patchy opacification, or reticulonodular shadowing. So that will be seen in your hypersensitivity pneumonitis. So your chest x-ray will be abnormal. And then a bronchodilator is not going to help. If it is occupational asthma, your chest x-ray will be normal in most instances because they didn't get time to have air trapping and all of those things. So your chest x-ray should be normal. However, asthma is reversible. So when you administer a bronchodilator therapy such as a SABA for your occupational asthma, the symptoms will improve. And so that is the answer to your homework question as well. So hypersensitivity pneumonitis, look at for your chest x-ray, classical chest x-ray, look for your entire patient history, right? See what their exposure is to. It's a farm, if it's malt, if it's sugar, if it's bird fancy, if it's mushroom, and that will be pointing towards hypersensitivity pneumonitis if the chest x-ray is fine, and your spirometry will also show that of a restrictive lung disease. So your your FEV, FVC will be more than 0.7. Compare that with occupational asthma. This is usually seen in people like bakers exposed to flour and so on, but there are other causes you should know of. But that's one of the common stems. And their chest x-ray is normal because it's just asthma. However, their symptoms are relieved or reduced or reversed on bronchodilator therapy. So do not mix up hypersensitivity pneumonitis with occupational asthma or with any of the other things that we would have seen in lung disease. All right. The other thing that they test on for interstitial lung disease is pneumoconiosis. Pneumoconiosis is inorganic dust that you're inhaling. So it's things that are just chemicals, it's just structures, things like asbestos, silica, iron, coal, beryllium, etc. It's inorganic dust. So these are your occupational lung diseases. It's not the same as occupational asthma, really. It's two different things. Asthma, reversible, normal chest x-ray. Occupational lung disease, not reversible. Spirometry shows restrictive pattern. Chest x-ray shows pneumoconiosis pattern. All right, so don't confuse them. It's an occupational lung disease, that's your pneumoconiosis, and these are the things that they're exposed to. All right, so asbestosis, silicosis, cirrhosis, anthracosis is the other name for co-workers lung, and berylliosis. Okay, and asbestosis would lead to what type of lung cancer, guys? You always seen it advertising on TV. Mesothelioma. Fantastic, right? So very easy. Nice. Good. So how they bring this question is they ask you which one of these is not a hypersensitivity pneumonitis, which one of these is not a pneumoconiosis, etc. Things like that. They ask you to differentiate between that and occupational asthma, things like of that nature, which I just explained. That's how they tend to bring the questions, right? The other thing they can bring that I've seen come is the actual causative organisms, and the most common one that they bring is the organism for farmer's lung, and that organism is used to be called Micropolyspora fani, and the new name for that is Saccharopolyspora I always butcher the spelling, but I think that's how you spell it. Saccharopolyspora. It has the same thing as Micropolyspora. So the polyspora, Saccharopolyspora, particularly rectivirula, because apparently there are many Saccharopolyspora. I don't know. I never did my B as good as I should have, right? But just know that that's one of the organisms that they test on for your farmer's lung. Right, and just not to confuse that, guys, what's the positive organism for rose handler's disease again? Rose handler's disease, the patient picking a rose, they develop some sort of pneumonia, right? It's an immunocompromised patient. They have now this long rash um, because of the rose thorns. They're a gardener and they got stuck, and now they want to know the causative organism. This is rose handler's disease. Guys? Right, yep. So sporadic Schenke, right? So that's sporotrichosis. Good. And that actually causes pneumonia in the immunocompromised. It doesn't cause uh, um interstitial lung disease. Cool. All right, so that's it for ILD. That's it for ARDS. That's it for pleural effusion. Oh, I have here Kaplan syndrome. So this question is just know what Kaplan syndrome is. Kaplan syndrome is the triad. So in patients with rheumatoid arthritis, they have an occupational lung disease, and then they do a chest X-ray, see pulmonary nodules on the chest X-ray. That's known as Kaplan syndrome. It's this particular triad. So how I've seen it come is a patient with rheumatoid arthritis, used to be working in old houses with asbestos exposure, and now they having this chronic cough, and when they do the chest X-ray, it's pulmonary nodules. So that's rheumatoid arthritis plus pneumoconiosis, that's asbestosis in that case, and then pulmonary nodules on the chest X-ray, and that is called Kaplan syndrome, right? Oh, and what's the other? What is so a patient has rheumatoid arthritis, splenomegaly, and neutropenia. What's that called? Felty syndrome, right? Yeah, Felty, Felty, right? Yeah, Felty syndrome. So Felty syndrome is rheumatoid arthritis, splenomegaly, neutropenia. That's the two triads that come for the syndromes in rheumatoid arthritis. When we do rheumatology, we'll see it all over again, right? So that's just a heads up. Good. Okay, everyone. Any questions on ARDS, pleural effusions, or interstitial lung diseases? Are we clear? You all ready to answer my questions correctly now? Yeah? All right, good. No questions. Nice. Let's go. So now,
Doc, I have a question.
Gabriel, what's up?
Okay, when you were talking about the difference between the hypersensitivity pneumonitis and the pneumocosis,
Pneumoconiosis,
coniosis,
yeah.
right?
Mm-hmm.
Can you talk about the chest X-ray and the bronchodilator? I think I might have got it mixed up.
Okay, no problem. Right, so remember your pneumoconiosis. So pneumoconiosis or your hypersensitivity, pneumonitis, right? All of them. This falls under the category of interstitial lung diseases, right? This is interstitial lung diseases fall under the category of restrictive lung diseases. Okay? So what I was saying is things like pneumoconiosis and hypersensitivity pneumonitis. So your pneumoconiosis is also known as the occupational lung disease, right? And the hypersensitivity pneumonitis is known as the environmental lung disease, right? These fall under interstitial lung diseases, which are all restrictive lung diseases. This interstitial lung disease, because these fall under that, their chest x-ray will reveal the same things that your interstitial lung disease reveals, which is your patchy opacification, right? Also, because it's a restrictive lung disease, your spirometry would reveal a FEV, FVC of more than zero point 0.7. And because it's a restrictive lung disease, it's not due to bronchoconstriction. It is a restrictive lung disease, right? It is due to because the lung cannot expand, so it can't inspire. Therefore, the problem is not with expiration, it's with inspiration, and therefore bronchodilators are ineffective. Bronchodilator, or I should say bronchodilator, will not reverse, right? So it's a restrictive lung disease. So yeah, more than 0.7 FEV, FEC is already there. So bronchodilator ineffective in these patients with pneumoconiosis and so on, right? So the chest X-ray will show that it's a pneumoconiosis based on Apache opacification. Spirometry will give you a restrictive lung disease picture, and then bronchodilators will be ineffective. Whereas if it was something like, as I was saying, with occupational asthma, this is, as the name implies, asthma. It's still asthma. It is still due to bronchoconstriction. Okay? But because it's an asthma, typically for asthma, the chest x-ray is clear. It's normal, right? But because it's bronchoconstriction, when you do SABA therapy or bronchodilator therapy, you will have improved FEV, FEC. And remember, asthma is an obstructive lung disease. So normally, asthma, COPD, these will give you a FEV, FEC ratio of less than 0.7. But if it's improved by more than 12%, it points towards asthma. Okay, so it's an occupational asthma, chest x-ray will be normal, and bronchodilator therapy will improve your FEV, FEC ratio. Yeah, that's clear, Gabriel?
Yes, thank you.
You're welcome. This writing thing just enhanced everything about these lectures. I can't see how I was teaching with all this and students passed. I don't know. I guess I could talk good because like this makes everything so much better. All right, any other questions, guys? Cool. All right. So, okay, well, let's just go in an ascending order. So answers to number 9 in the chat, please. Answers to number 9 in the chat, please. Okay, excellent. Um, Julian? Julian, was that an error or you need me to re-explain? Oh, okay, yeah. So which of the following is, so this patient has the whiteout, classical, bilateral pulmonary infiltrates on chest x-ray and it's COVID-19. Guys, you all can get questions on COVID-19, by the way, which I also did not teach. Sorry about that. But COVID-19 came from my paper in 2022. So it can come, right? I think it came again in 2023. Can't remember, buddy. 2024. Yeah, boy. I don't even know what COVID-19 is. Just like a no, I really don't know what I don't know what it is. I feel like it was just this matrix that we were in. Anyways, so COVID-19 was a common cause of still can be, but the reason a lot of patients died is because they went into acute respiratory distress syndrome as a result of the COVID-19. So this is a typical chest X-ray of ADS. And which of the following is most in keeping with the diagnosis? Well, A is wrong. It is a PaO2 FiO2 of less than 300. B is wrong. We said it's bilateral pulmonary infiltrates that are not explained or not due to effusion. So B is wrong. D is wrong. It's lung injury or within 1 week of lung injury or insult worsening respiratory symptoms within 1 week of the onset. So A, B, and D are all wrong. So what is correct is actually a normal finding on echo, because a normal finding on echo helps us rule out cardiogenic causes of this pulmonary edema, right? So I'm 100% satisfied that you all have gotten that correct, because there were a lot of wrong answers and I think everyone understands it. Great. I'm moving on once no questions. I think that concept is clear, right? You see all the answers in the world to this one. Okay, fantastic. Excuse me. Right, so which of the following easy question is not a cause of pneumoconiosis? Well, pneumoconiosis is our occupational our occupational lung disease due to exposure to inorganic allergens, right? So things that are from basically material. And so silica, beryllium, siderosis is iron, coal workers lung, that's coal. All of those things are exposure to inorganic materials. All of those are pneumoconioses. Whereas bagazosis, those it ends in osis, is due to sugar cane exposure. So it's seen in that sugar workers lung. And so that's a hypersensitivity pneumonitis, also known as extrinsic allergic alveolitis. Okay, so make sure you know the two interchangeable names of them. All right. Good, fantastic. Hi, number 11. Well, this is clearly farmer's lung. I asked you all about that. 32-year-old farmer presented to ED, shortness of breath, cough, and a headache. He describes heaping hay on his farm during the morning and developing an irritating cough whilst having dinner. Right? So this distribution of the symptoms, guys, this form of, let's say, this helps differentiate it from occupational asthma, where in occupational asthma, the patient has symptoms on exposure, but it's relieved when they're not exposed to the pathogen. They're not exposed to the flour in the bakery or whatever. In this case, he had a delay because it's a delayed type of reaction. It's a type 4 type of hypersensitivity reaction. And so he was exposed to the material in the morning, but his symptoms started in the evening. And that's another way of differentiating hypersensitivity pneumonitis from occupational asthma, right? And of course, we see a nice chest x-ray with our bilateral patchy infiltrates. This is not clear lung fields at all. Okay, it's kind of worse on the right side. And so all of this points towards a interstitial lung disease picture, a hypersensitivity pneumonitis picture. And so this is farmer's lung in a farmer. So that's C, Saccharopolyspora rectivirula. Great. And when you do the homework, you'll see the question I have, and you all will choose the correct answer based on our teaching for sure. All right. Okay. And number 12. Number 12. Answers to number 12, please. Right, fantastic, right? So we see no more disparities in that. This is a 65-year-old female presenting for progressively worsening dyspnea, dry cough, right? Songs like pleural effusion. She has stony dullness to percussion, absent breath songs. And what will happen to the tactile vocal fermenters here, guys? In pleural effusion? Mm-hmm. So it's decreased in pleural effusion, but increased in pulmonary edema. Fantastic. A chest X-ray shows a moderate sized pleural effusion. Pleurocentesis is performed. Guys, remember not to. So another thing they like to trick you with is thoracentesis. So thoracentesis is they're using the needle, right? Um, so that's pleurocentesis, thoracentesis, okay? As compared to tube thoracostomy, and this is a chest tube. So if you see thoracostomy, that's chest tube. Thoracentesis is where you use a needle, right? So let's don't confuse the semantics. So the pleural effusion had a concentrate of 40. So hey, look, they tell us. All right, guys, we could safely assume that this is most likely to be an exudate. So which is least likely to be associated with an exudate? Well, we said there's three things with exudate: infection, inflammation, malignancy. Inflammation refers to autoimmune diseases as well. So let's look out. So infection, pneumonia; inflammation, RA, SLE; malignancy, bronchogenic carcinoma. So A, C, D, and E are all causes of exudative pleural effusion, and therefore they can be associated with this type of picture. We'll have to do yeah, and it's usually due to lung injury. Good, Anton. It's usually due to lung injury, not necessarily lung related, because things like lupus and rheumatoid arthritis are lung related, but they are inflammatory processes that lead to lung injury, right? So that's the exudate leading to lung injury. Whereas cardiac failure doesn't lead to any lung injury. What it does is you have a rise in your hydrostatic pressure, increased venous pressure, and that's what causes fluids to leak out more than proteins. And so that's why I get a low protein count in transudates. So cardiac failure is unlikely to cause such a high protein count. So B, cardiac failure is least likely to be associated. 100% correct. You all were paying attention for a whole hour, 50 minutes. Good thing about this is we will take a break till 8 o'clock. The good thing is the only other topic I'm going to teach is the easiest topic in the world to teach because you're a year 5 students. That's pulmonary embolism. And I will just touch on acid-base disturbance. I'll go through the question with you all here and just like direct what you're supposed to know about COPD. You'll watch Ninja Nerd for COPD. All right, so we'll take a nice break because we're actually going to finish early because pulmonary embolism, all I'm going to tell all you is ECG findings, start some heparin, send them home on a Viroxaban, CTP is the gold standard, and you're good to go for pulmonary embolism, right? So we'll start back on 8 o'clock. Okay, guys?
Seth,
Uh, yeah,
yeah,
Anton.
but this one ask an
Sure.
unrelated question. You remember when you were,
Unrelated question.
yeah, about, it's
Uh-huh.
not so, when you were talking about lung cancer one time, and
Right.
you said small cell lung carcinoma, you said it
Yeah.
can't be seen on what X-ray, or you said something like it small to
Oh,
remember it's
small
small
cell?
cell.
No, no, yeah, to
Yeah.
remember it, I was telling you about the treatment of small cell lung cancer. The reason that they categorize small cell versus non-small cell, most of it has to do with how they treat it. So, small cell cancer versus non-small cell. And cancer, you have really three options. You could either chop it out, or you could do chemotherapy, radiotherapy, or systemic therapy. So, basically, two options: systemic therapy or chop it out. So, for small cell lung cancer, I was saying that the cells are too small for the surgeon to see. That's just a way of remembering that small cell lung cancer you cannot treat with surgery, right? You don't treat small cell lung cancer with surgery, you treat it with chemoradiotherapy. Whereas non-small cell lung cancer, non-small cell, the surgeon could see it as big cells. So you treat non-small cell lung cancer with surgery. So the small cell lung cancer is with chemo and therapy because the chemo and radio because the surgeon cannot see it, they're too small to see. And non-small cell we treat with surgery. And so that's also why small cell lung cancer has a worse prognosis because we don't chop it out. We don't do surgery. And if you can't chop out the cancer, it's just going to grow, 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 grow. So chemotherapy and stuff is really ineffective for solid masses. Chemotherapy and all of that is more effective for things like hematological disease and so on. So that's why with breast cancer, we chop it out. That's why with lung cancer, we chop it out. So any solid type of cancers, we tend to prefer surgery as a whole standard. So for small cell, the surgeon can't see it, they can't chop it out, worse prognosis, but we'll still hit them some chemo radio. Non-small cell, well, surgeon can't see it, and so we'll chop that one out.
Okay, yeah. I had mixed up what it meant in the
Yeah,
over.
yeah, it was just a figurative way of saying, yeah,
Yeah. All right, then. Thanks.
yeah, no problem. All right, guys, so we'll start back. Well, Anton had me talking for 3 minutes, or I should say, I had myself talking for 3 minutes. You know, I like to over-explain stuff, just to make sure you're all clear. We'll start back at 8:02, 8:02. All right, 8:02, guys. Hey guys. Um, so I wouldn't chat too much today because it's already 8 o'clock. And I'm actually trying to be proud of myself and see if I could finish by half eight. Right. So I'll get to know all of you. I'll get to speak to all of you at least once before the course is over. But we'll just go straight back into it. Everybody here, I could just see some yeses in the chat, please. Make sure you're all back. Okay, Christina, Celine, Diva, Celine, cool. All right, cool. So I had a lot of fun. I had a lot of fun thus far with this course, man. Like this, I see a couple of people message me like just now, and they were like, the join helps, and I've never, because I dunce, right? Technologically, I am dense. I am stupid. I don't know anything about technology. This is my girlfriend's laptop, so gotta thank her. She's a boss. She helps with everything in terms of organizing like this document. Like I can't make this kind of stuff. It might seem simple to you all and people who know about, but I cannot do this. I can't make this that seems simple is fascinating to me. Yeah. Well, but it's hard for me. Okay, Monique, it's hard for me. All right. Sorry, I'm not Steve Jobs or Elon Musk on a guy. Okay, it's very difficult for me. So she um she has definitely helped enhance the course in many ways. And this join thing, she was like, hey, my laptop have this pen thing. My laptop is just this old small thing. As far as I know, the work in my head, I come and talk or I listen. But it really does add a different element, I guess. And I haven't seen any lecturers, at least at university level, when you get to year 4 and 5, lecturers don't really teach like that. They don't really spend time explaining. So I think it helps enhance the teaching, and then it helps enhance your understanding, which is the most important thing, and therefore you remember. So thanks for the encouragement, because obviously I can't draw, I can barely write. You all see my handwriting. The handwriting that you see on the screen is the handwriting that you're going to see in my notes. And that's why the nurses always say, Dr. Knight, just tell me what to do now. Just tell me what to do. No bother to write it, just tell me. Right? Because my handwriting is atrocious. Um, but at least it helps you all understand. Right? So yeah, no, for real, Eva, like if you students on my team, if they like go through my file and stuff and they trying to copy my history, just don't bother. Just don't bother. Just go and take the patient history for yourself, because you're gonna mix up some words. You're gonna see MI and think PE, and so you're gonna thrombolyze a patient when the patient had a hemorrhagic stroke or something. So don't bother to read my notes, right? So good. That's my rant and being engaging and funny and all of those things I supposed to be to keep people engaged. All right, guys. So um, we're gonna do pulmonary embolism in like 5 to 10 minutes. I'll see if I could do it in less than 10. See how that goes. And I will do. Yeah, yeah, yeah. I have been told that I am not the worst. And if there's worse than me, then that sucks. Poor readers. Yeah. So we'll do pulmonary embolism. Simple question here for you guys. And I will teach P pulmonary embolism P. Big topic, huge topic. But because it's so huge, I am coming with the assumption that you all know everything about it. But I will still point out the high yield stuff. Good. So answers to number 16, please. Answers to number 16 in the chat, please. And look at me assuming you all know everything about pulmonary embolism. Goodness me. Oh, okay. The answer's now coming in. It's probably a delay on my end. Hmm. Yes. That's it. That's it for the answers. Pulmonary embolism. That's it. No more answers. So remember, I was telling you about my terrible use of technology. I just minimized something and I couldn't unmute my mic. It's a struggle over here. All right, cool. Thanks, guys. Thanks, most of you all, for participating. And we see mixed answers. Good. All right, so let's pay attention. Let's pay attention here. Good. Pulmonary embolism. By now, we all should know how a pulmonary embolism most commonly happens, but it's not the only way that it happens. So we'll start first with deep vein thrombosis, and we'll teach here. Right? So DVT, guys, DVT, deep vein thrombosis, deep in a deep vein thrombosis, thrombus clot formation, very easy. It doesn't only happen in the legs, it can happen in the upper limbs, and usually when you have an upper limb deep vein thrombosis, um, you get vascular surgery involved because upper limb, okay, okay, what can cause an upper limb deep vein thrombosis that you have to rule out? I actually learned this as a house officer not too long ago. We treat them basically the same in terms of anticoagulation and stuff, but we have to refer them to vascular surgery apparently. And Dr. Pran, who's the vascular surgeon at Mount Hope, if we get a upper limb DVT and he doesn't know about it, well, the ass is grass. Right? So you need to get a chest x-ray and C-spine x-ray. Nah, nah. Upper limb DVT, right? It's a upper limb deep vein thrombosis. It's the same thing. Right? We have to rule out why would you have a deep vein thrombosis in your hand. So we have to rule out chest X-ray and C-spine. We have to rule out thoracic inlet syndrome. So we need to look for compression by a cervical rib that could compress the vessel and lead to stasis of blood flow and so on. Okay, so that's something that I learned as a house officer not too long ago. So these patients have to be referred to vascular, and vascular decides what to do there because deep vein thrombosis in the upper limb is by far more rare than it is in the lower limb. Okay. Good. So deep vein thrombosis in your leg, it tends to happen in your leg. Right. So this is a patient leg here, but it can happen in the upper limb. Right, and it can happen. My gosh, it's a skinny leg. Right, this is the patient's thigh, so it could happen anywhere along here. You have a femoral vein, so you just want to put femoral vein here. It actually comes from your internal, external iliac vein. So EI for external iliac. Come your femoral, you have your profunda femoris, your deep femoral given off your superficial, your popliteal vein. We're gonna do all of this in vascular, and when your tibioperoneal trunk and all that. Basically, I don't even know why I joined this. Basically, deep vein thrombosis is this big clot here in a vein. Okay, and so when you have venous thrombosis, you need to remember this thing called your virtual